Good morning, everyone. I think we'll just get started today for today's face-to-face and webinar session that we've got here, being held by the Brain Cancer Group and Brain Tumour Alliance Australia in collaboration. My name is Marina Castellan. I'm a neuro-oncology nurse practitioner that works for the Brain Cancer Group. I've been with the group for a few years. A big part of my role is around support and education, so that's the part I play within the group, and I'm proud to do that. Just a little bit of housekeeping. So we'll do the first session. At the end of the first session, we'll have the Q&A, where the doctors will come up to the front, so save your questions for that. Then there'll be a short morning tea session before we go on to the second part of the day. And then we'll have lunch after that. The toilets are actually if you go back around to out the front doors to the left and around to the main front foyer of private hospital. The toilets are just in there as well if you need to go. I'd like to begin by acknowledging all the traditional custodians and pay respects to elders past and present as we endeavour to serve the health needs within the community. We recognise the importance of the land and the waterways as an integral part of people's health and well-being. I'd like to now introduce Dr. Raymond Cook, who's a neurosurgeon at Royal North Shore Hospital and North Shore Private Hospital, and he's also the chair of the Brain Cancer Group. Thank you, Dr. Cook.
So this is yet another in our series of symposiums on aspects of brain tumours. This one is with focus on relapse, mostly relapse of gliomas. It's a very difficult subject. It's both emotional and scientific in terms of what we do when this terrible disease comes back. Obviously, common sense tells you it's you're going to be looking at again potentially surgery, perhaps more some radiation, perhaps some change in your chemotherapy or another form of novel therapy. And the speakers that we've got today are going to try and address all of this. I think the biggest thing for me to emphasise is that when you see one of us, whether it's a surgeon or an oncologist or a radiation oncologist, the idea is that you get an unbiased appraisal of what is the best, what is the optimal treatment for your relapse, not just what that particular person has in their weaponry to treat that. And that's what I want to emphasise, that like the collaboration between our two societies, there is a lot of collaboration between the surgeons and the physicians here, so that the concept is that you get this overall management plan when you see one of us or either of us or all of us. And we all sort of sing the same song. It is complicated though, because particularly for relapse, there's no sort of universal pathway. It depends very much individually on how the relapse has occurred, what the biology of the tumour is, and it's somewhat difficult, and even to make up our mind on which is the best pathway forward. There's a lot of discussion between the group to try and work out the sequence, and it's often just not one or the other. It's often a combination. So we'll start off with running through all our speakers and look at all these different ways of treating these relapses one by one. Cheers.
I'd like to now introduce Catherine Heinzen from Brain Tumour Alliance Australia, just to say a few words.
Hi, I'd just like to welcome you all. It's wonderful to see so many people here. It makes it very easy when people ring us looking for support and help, to have the Brain Cancer Group putting on these forums, because they're all recorded and we're able to say this is where you can get information. And I'd like to thank all the doctors that have given their time today to come and inform us on what can be done if your tumour gets back. And thank you, Marina.
Okay. So our first speaker is actually Associate Professor Michael Back. who's a radiation oncologist here at Royal North Shore Hospital. He's actually going to do Dr. Drummond's talk on, is it really relapse, or could the MRI abnormality be an effect from treatment? Because Dr. Drummond's mid-flight at the moment, so Dr. Back's kindly going to do his talk.
Thank you, and thank you for the opportunity to talk about this important issue. Jamie Drummond is our neuroradiologist, and he offered to do his talk from the airport because he gets in around 8:30. I said, don't do it. So I'll do it instead. Yeah, one of the big perplexing issues we face when people are on surveillance MRI scans or surveillance care after treatment is that the potential for misinterpretation of MRIs. Now, obviously, there's a high risk there is tumour relapse in many cases, but MRIs take a lot of interpretation, and working out the imaging details can be difficult. So just a bit of a refresher on management pathways of what happens to people over a course of treatment. New diagnosis going through to radiation therapy and chemotherapy, and then follow-up. And then at follow-up, after treatment, there's surveillance, which is really looking to see if there's any response or diagnosing progression or relapse. Two main modalities we use, apart from clinical examination, is MRIs. It's good just to refresh what they are, even though many of you have been through many MRIs. MRIs are looking at structure and the density of tissue to try to work out if there's an abnormality or asymmetry, whereas a PET scan's looking at function and metabolism. So we're looking at different things. The MRI, as we can see here, shows an abnormality, and the PET scan can show that abnormality as well, but it's looking more at the function, how those cells are working. With the MRI scans, we can do sophisticated sequences and try to identify different metabolic areas within the brain or within a tumour or an area of inflammation. And the main two principal scans that we look at are the T2 sequence or a T1 GAD sequence. This is the one which shows enhancement after the injection, whereas the T2 is looking at the cloud or the flare in many cases. There are many many PET scans which can be performed, and the main one which is covered by Medicare is the sugar PET scan, which doesn't have a lot of role in brain tumours, but we've also got other novel and newer traces that can be used, and the most emergent one is FET PET, which has been around and being utilised in New South Wales for more than 10 years, but that's not Medicare funded at the moment. And that probably gives you a better definition of the extent of a tumour. But there are other novel isotopes coming through which might be able to delineate different metabolic pathways within a tumour or within areas of the brain. So they're the sort of modalities we might use. And when things are pretty straightforward, this is a scan of a patient who had a tumour before their radiotherapy, 3 months afterwards, and 12 months afterwards. The tumour's reducing in size and there's no new lesions. And that's a straightforward response in a patient here who has got one of those more favourable subtype tumours or an IDH mutated tumour. But the imaging can be quite difficult at times. This is another example of a patient who, starting from here over an 18-month period, his MRIs. Tumour here, which has responded, flared up, came down and went away. Meanwhile, in another area of the brain, a new area came up, arose, and then went down. So the key aspect of that is one abnormal MRI scan, one abnormal result may not mean relapse. And the best tool we have in looking at things is really sequential MRIs, looking at things over time to see what the response is and how things are going down. Now, if you get an abnormal scan after treatment, there can be a number of different reasons for that. Obviously, we're concerned to see if it's actually true relapse. It could be just something by the nature of the MRI and the quality of the MRI, or it could be, in many different and difficult situations, post-treatment effects. So first thing with the MRI imaging, not all MRIs are equal, and not all MRI sequences are equal. So the MRI factors which might make the scan look a bit different include having it on a different MRI unit, even in the same radiology practice, different MRI sequences being performed and different slice intervals. So some scans might give you 200 images, whereas others might give you 40 images. The head position might move, and as a result you might cut through the tumour at a different angle, and that might look bigger in one plane. Or, and some people move in MRIs, it's not very comfortable, so you can get movement artifacts. And also, when we're looking at MRIs, we've also got to remember that you're human beings underneath all this, and other things might be there apart from cancer. So here's a good example of way things can change over time. This is the MRI scanner just around the corner here, and this is the same sequence from 2015, 2018 and 2022. And what we can see there is a marked improved quality in over a period of 7 years due to a change in the software rather than a specific change in the MRI. This is still the same intensity MRI, but the sequences have improved and it's much more detailed, and as a result sometimes you can see more things which you didn't see previously. So the general principles in this first aspect is really we want to look at sequential MRIs, hopefully on the same MRI unit, and if you do have something which is described at relapse, then have that relapse reviewed at a neuro-oncology multidisciplinary team meeting where all the doctors come together. But the most perplexing area probably comes to post-treatment effects, and this is the one which gives us most difficulty in the clinic. And often you may come back with an abnormal scan and we might say, hey, let's just sit tight and repeat the scan in 4 weeks or 6 weeks' time as we try to work out whether this is actually true relapse or whether it could be one of these other abnormalities. We know from biology, we know from people we treated, and we're getting more information on this in recent years, is that radiation changes occur in the brain after treatment, and they're not the old classical model of a little blood vessel being abnormal and a stroke. We're actually seeing this pathway of neuroinflammation coming through and subsequent blood vessel effects and mounting immune responses within the brain. And some of the medications we give in addition to the radiotherapy, the chemo drugs, can sometimes enhance these as well. So when we see that treatment effect after treatment, and this is a lady with a glioblastoma, we see marked enhancement of the abnormality. So when we give the injection, the MRI scan, it enhances quite prolifically. And it also might swell, where we get this cloud around here, or edema, and that's on the T2 sequence. So we're looking at more than one sequence. And this, in June 2020, just looked like tumour. This lady actually came back for follow-up on Monday, and that's the changes now after no subsequent treatment. So all those changes which we were concerned were tumour, over time just went away because of inflammation. Now that's a good story. It doesn't always happen like that, but we've got to be aware that those cases do occur. So to try and get through this confusion, we look at a number of different aspects. We look at the time from radiotherapy. We look at the molecular subtype of the tumour, because some tumours may swell more, other tumours may shrink more. We look at the initial MRI to try to work out exactly where the tumour was and where there might be clues there may have been tumour that subsequent radiotherapy has brought to light through inflammation. And the key is really correlating to the radiotherapy field and looking at where the radiotherapy is being delivered. So here's a patient who had abnormalities in this part of the brain. When we mapped out the radiotherapy field, the areas that lit up matched exactly to where the high doses were. This was a confusing patient many, many years ago who had an abnormality here when his tumour was over here. We didn't know what that was. It was a long way away from the tumour. And then we mapped out the radiotherapy, and it was in the radiotherapy area in a very low dose, and that was a vascular effect, and it went away. We've looked at this group of patients, especially in the patients with glioblastoma in the 6 months after radiotherapy, and tried to work out how much of the swelling we get after treatment is actually related to tumour relapse, or is it related to treatment effect? And we published this data 2 years ago, and what we showed was that in patients with glioblastoma within 6 months of radiotherapy, about 18% of patients had a swollen symptomatic enhancing mass. This is out of about 400 patients. Repeat surgery was done in 49 patients, and in that time frame within 6 months of radiotherapy, if you did repeat surgery, more than 70% of patients had treatment effect and not tumour. So even though the scans were concerning when we did the operation, it was demonstrated to be treatment effect and not tumour. And here's an example of what happens when a patient gets a bit of treatment effect. It increases and then decreases over time. And that's the scenario we like to see, but unfortunately we may not see that. We can also see it where we might see an area of treatment effect here, and we saw that and we thought that was treatment effect, and it did remain treatment effect, but right behind it, on the other side of that arrow, the tumour arose. So unfortunately you can have both treatment effect and tumour in the one scenario. The other perplexing area is in patients with more favourable subtype tumours, the RDH mutated tumours, meningiomas. We can see treatment effects coming out 12 or 18 months or more afterwards. And these often occur around the fluid areas in the brain or the ventricles. And there's just an enhancement around the rim of the ventricles, which can appear, look like relapse, and then go away. In our data, we're seeing this in around 20 to 25% of patients who have been treated for RDH mutated tumours. There's no gold standard for trying to determine this treatment effect. We do novel MRI sequences, and we've also got amino acid PET scans. The FET PET scan is quite promising, but when you see an abnormality, and you might see an abnormality on the FET PET and the sugar PET, and it looks like it is tumour, it can actually not be tumour. And this is one example which went away. So a single PET scan may not be useful. What's more important is, and what we're learning about the FET or the amino acid PET scan now, is we need to do a dynamic test where we don't just take one snapshot image, we repeat the image after 20 minutes, 40 minutes, and even 60 minutes to see what happens with the uptake over time. And that gives us more of an idea, but that isn't a routine test at the moment, but we're learning about that. So in summary, PET scans and MRI scan interpretation after treatment can be difficult. It can be misleading, and we need to look at it in a very academic way and analyse especially sequential MRIs, so looking at them over time, if you have that time, that is, as the most reliable assessment. With PET scans done in the appropriate way, providing additional evidence to the MRI, but the MRI changes are the most important ones. And in all situations, we recommend that if there's an abnormality and people are being managed aggressively for that abnormality, then we should have management done in a subspecialised forum such as a neuro-oncology multidisciplinary team meeting. And I think Jamie, as well as everyone else, would like to thank the Neuro-Oncology MDT at North Sydney Cancer Centre. And most importantly, part of this MDT, we've got 2 medical oncologists, we've got a neuropathologist, we've got the care coordinator, but we've got 3 radiologists, 3 neuroradiologists, and 3 nuclear medicine physicians who all provide input to our patients. Thank you.